Dr. Adel Al Tammimi is a consultant emergency medicine, and he's the chairperson of the Department of Emergency Medicine at King Abdulaziz University Hospital. We welcome you, Dr. Adel.
Good morning, everybody. It's nice to be here in beloved country, Kingdom of Bahrain. So I'm talking today about a topic in the track of cardiovascular. However, the presentation more of general emergency management than cardiovascular. So I'm talking about the new anticoagulant, which was called NOAC, or novel anticoagulant. Now, not anymore new, it's an older news. So let's start with the story. An old man, and 75, with a multiple medical problem, hypertension, AFib, diabetes mellitus, came to your AD with a history of vomiting blood. He vomited twice in the morning, he vomited twice in the ED. His vital sign is blood pressure 100/80, heart rate 100. He looks sick. So you will do all the measure needed for the upper GI bleeding, plus the decision for reversal, because he AFib. So if this patient came to you before 10 years in the AD, most likely he will be in warfarin. Warfarin is an old drug. It was established to use in 1954. Since that, a lot of things happened. Neil Armstrong walked on the moon in 1969. Bahrain independence was in 1971. Prince Sultan was the first Arabic man to be a part of NASA mission to space. 9/11 happened in 2001. So a lot of things happen. This stay until 2010, when we start to have the new anticoagulant, or what we call it now, DOAC. The first one was dabigatran, then followed by rivaroxaban, apixaban, and the others. So in the mechanism of the action, the dabigatran work by blocking the inhibition of the thrombin, so will inhibit the formation of the fibrin. The 10A inhibitor will inhibit the 10A, so will inhibit the formation of the thrombin. So, is DOAC better than AFib? So, a lot of things that can compare to the DOAC to warfarin. So, there's a lot of multiple randomized trial controlling or comparing DOAC to warfarin and the AFib and the VTE. All of those found that it's better in the safety and with the less mortality rate. So now, the DOAC is already in the guideline. There's a lot of advantage. It's rapid onset of action, shorter half-life, less food and drug interaction, predictable pharmacokinetic, and no need for monitoring. For the last point, some will argue that this is more of disadvantage for NOAC more than advantage. So as I mentioned, it's already in the guideline. CHEST guideline recommended to use DOAC as a first line in the AFib and also in the VT treatment. So this is just a quick comparison between the dabigatran, rivaroxaban, and apixaban. The time to peak is, as you see, is rapid, 1 to 2 hours versus 2 to 4, 1 to 3. Half-life, 12 to 15 hours in the dabigatran, 5 to 9 in the rivaroxaban, and 8 to 15 in the apixaban. Clearance, 80% renal. This is very important in the management, and we'll see why. So when you see a patient, our patient in the ED, and he tells you that he is on rivaroxaban for his AFib. So just to make sure that in my talk, I'm talking about the reversal. You decide to reverse this patient. I'm not talking when you revise him or what the indication for revise. I'm talking about this, you decide to reverse this patient. So there's actually three important questions to be asked in this scenario. First one, when the last dose of DUAC was taken, what is the half-life of DUAC he's taking, and how's the renal function? These three questions will decide about your approach of treatment. So, the half-life is very important, so the interval since the last dose. The anticoagulant effect will be fully resolved after 5 half-life elapsed since the last dose. So, as I mentioned, the dabigatran is up to 12 hours. So that means after 2.5 days from the last dose, the anticoagulation will be resolved, providing his renal function is normal. Right. Do you have a blood test to measure the coagulation to the effect of DUAC in the ED? We have our usual, the coagulation profile, BT and BT. Are those good in detecting the DUAC activity? So it is available in all EDs. The problem that there's a poor correlation between DUAC's plasma concentration and our coagulation profile. Prolonged PTT can predict there's some anticoagulant effect of dabigatran, and prolonged PTINR can predict there's an anticoagulant effect of the rivaroxaban. However, you have to be cautious. Normal PT and INR, or normal INR and PTT, cannot exclude the anticoagulant effect of DUAC. Even with the normal level, you can have a chance of the anticoagulant effect. You can't use it for the measuring the supratheoretic or the thoracic effect of DUACs. Do you have a gold standard test for detecting the DUAC anticoagulant effect? Yes, the problem is not available in all the ED or all the hospital. So the anti-factor 10 activity levels, it measures all the anti-factor levels. It should be calibrated for the drug you take. So if you're taking heparin, it should be calibrated to the heparin. If you are taking rivaroxaban, it should be calibrated for rivaroxaban. And if you are taking apixaban, it should be calibrated for apixaban. But if it is negative, that means there is no 10A activity on board. How about direct thrombin inhibitor? This is for dabigatran. Thrombin time, usually it's a very sensitive. If it's negative, it's negative. There's no DUAC on board. But if it's positive, small amount of dabigatran can elicit the test to be positive. The more specific test is diluted thrombin time. The problem with those tests is not available. You can't do it. I can't do it in my emergency department. I'm not sure most of the emergency department, they don't have those tests. So let's decide, we did the anticoagulation, BT, BTT all high, the patient bleeding, and we decide for the reversal. So what we do for those patients? What is the agent of reversal for the patient on DUAC? Let's start with the fresh frozen plasma. Fresh frozen plasma is everywhere. You can't get it in any hospital in ED. It's cheap, it's good, it's old. The problem with the fresh frozen plasma, the amount of factor 10 is low. And if you end by giving a fresh frozen plasma for those patients, you will give them a lot of fresh frozen plasma. You are risking giving the patient trali and taco. What about BCC? BCC now is everywhere. 4-factor BCC. 4-factor BCC usually it's FDA approved for rapid reversal of the agent vitamin K antagonist. It contains 2, 7, 9, 10 plus protein C, protein S, and some heparin. There's a limited data in the DUAC, but we'll talk about it in the next slide, inshallah. So, the drug with a difficult name, idarucizumab. So, idarucizumab is the antidote for dabigatran. It was approved by FDA in 2015. It is a monoclonal antibody fragment that binds to the dabigatran with an affinity of more than 300. The dose usually 5 grams. Usually it's given 2.5 doses separated by 10 minutes. We'll talk about cost. So the first trial about the idarucizumab was published in New England Journal of Medicine in 2015. There was 90 patients. Group A was 51. Those patients, they divide them as a life-threatening bleed. Group B 39, those patients need reversal within 8 hours for surgical or for emergency surgical procedure. Primary outcome was reversal 4 hours post-infusion. So the outcome is not a clinical outcome. It's more of laboratory outcome. At 4 hours, 100% complete laboratory reversal. Laboratory. Median time to hemostasis, which was one of the secondary outcome, was 11.4. Just put in your mind that the half-life of dabigatran is 12 hours. So the hemostasis here is 11.5, which is almost the same. There was 5 thrombotic events. This small study was enough for the FDA to approve the use of the idursulfimab as DOAC reversal. The full data came in 2017, 500 patients, again, 4 hours, full laboratory reversal. The median time for the hemostasis was 2.5, much better than before. Just put it in mind, there's a lot of missing data in this trial. So you can see a lot of this data trial. There's a lot of limitation. But important thing, there's 2 important limitations for this trial. One, there's no control group. This is not a trial. And the author said it was unethical to give a patient a placebo or no treatment to compare it with the idursulfimab. However, they can give BCC. BCC, approved in British Journal of Hematology in the guideline, recommended the use of protein thrombotic complex for dabigatran reversal. So they could compare to the BCC to the idursulfimab, but they didn't do. The other limitation is there's a huge conflict of interest. The company who made the drug, it's the same company who made the antidote, it's the same company who ran the trial. Having said all that, idursulfimab in the guideline. So you are stuck now. So 2015, 2016 neurocritical care, 2017 American College of Cardiology, all put a dabigatran a first choice to reverse the idursulfimab, the first choice for the dabigatran reversal. How about the other one? The andexanet alpha, approved by FDA also in 2017. Sorry, in 2018, it wasn't here. It's derived from the Chinese hamster ovary. It's an antigen that competitively binds to the 10A inhibitor. The dose is not like the idursulfimab is clear. It's more complicated. There's a high dose, there's a small dose, so it's more complicated process. So another study, small study, 67 patients with a major bleed within 18 hours from the last dose of the 10A inhibitor. They have a co-primary outcome. So the co-primary outcome was the change in the anti-factor level and the rate of good excellent hemostasis in 12 hours post-infusion. The full data of this study was published in 2019, a prospective open label, 63 center, 350 patients. Again, it's a co-primary outcome. What they found, 92 of patients had a reduction in the anti-factor 10 activity, 82 of patients had excellent or good hemostasis, and 10% had a thrombotic event within 30 days. Again, this is not a trial. This is observational. The outcome was measuring is lab test. It's not a patient-oriented outcome. There's no mortality here. The thrombotic event here is significant, 10%. 10 to 12%. So there are a good amount, a good percentage of thrombotic event. The price of this drug, do you know how much per dose? $50,000. $50,000 for a dose of andexanet. The price for the idursulfimab is $1,500. So the cost is insanely expensive. Is this enough to use the andexanet? So this is another study. This is the role of BCC in the intracranial bleeding. The BCC work in 69 patients. So should I use BCC or should I use andexanet with the high expensive? Andexanet is more expensive, and the event of the thrombotic event is more than BCC. Luckily, the BCC is still in the guideline. A lot of guidelines still recommending the use of BCC over the andexanet alpha in the treatment of the DUAC or the rivaroxaban overdose. So, just to summarize everything. So, dabigatran investigation, the best is thrombin time if you have it. If you don't, you will go with the BTT. The reversal is idursulfimab 5 gram. If you don't have idursulfimab, go with the BCC. For hemodialysis, as I mentioned, dabigatran is a renal excreted. It's a less protein bound, so there's a good chance for hemodialysis. However, putting a catheter line in a bleeding patient, it's a very risky business. What about the 10A inhibitor? The test is anti-factor level if you have it. If you don't, go with the BCC. Reversal, go with the 4 BCC. And hemodialysis, no role for hemodialysis. I'm done. You can ask me through my Twitter or through my email. Thank you very much.